Hello, everyone, and welcome to this explainer. I am absolutely thrilled to guide you through today's fascinating topic. We're looking at a brilliant pedagogical framework called ViBrowns, and specifically, we're zeroing in on stage 5 of this framework, which is the research layer. It's a stage entirely dedicated to establishing medical truths beyond just a single patient. So, if you've ever wondered how medical evidence is actually synthesized from hundreds of published papers without losing the really crucial details, well, you are in the perfect place. We're going to explore how this framework uses something called evidence mapping to literally map out clinical truths. Let's get into it. Okay, let's dive into this with a bit of a medical mystery. Imagine you're bitten by a highly venomous snake. The obvious immediate treatment is snake antivenom, right? It's a total cornerstone of emergency medicine. But what happens when the absolute highest tiers of medical research, the so-called gold standard trials, fail to definitively prove that this antivenom actually saves lives? Does that mean the medicine doesn't work? Or does it mean our system for grading evidence has a massive blind spot? That is the exact paradox we are going to unravel today using the Vibrown Stage 5 methodology. Now, to make sense of that paradox, we first need to look at how Vibrown structures learning. The earlier stages of the framework, stages 1 through 4, are all about the single patient. They involve Socratic learning and guided discovery. You might run a bias audit or look really closely at one patient-specific presentation. And that is fantastic for single-case reasoning. But a finding drawn from a single case, no matter how rigorous you are, it's still just an observation about that one specific case. Stage 5, the research layer, completely moves the bar. It asks a much bigger question. How do we generate claims that hold true beyond the patient sitting right in front of us? It essentially shifts our focus from one patient to an entire corpus, synthesizing published literature across many, many cases. So how exactly does Stage 5 clear this new, much higher bar? It relies on a really powerful tool called evidence mapping. Now, evidence mapping is a recognized form of secondary research. It basically sits just one rung below a formal systematic review. But its absolute superpower lies in its discipline. Evidence mapping pulls the actual published literature on a clinical question and synthesizes it across all evidence tiers. So we're talking case reports, observational data, randomized controlled trials. But crucially, it does all this without pooling incompatible data together. It keeps each tier's contribution completely separate and visibly distinct. And honestly, this is where the magic really happens. Think of a standard pooled meta-analysis kind of like a blended smoothie. You take your case reports, your observational data, and your randomized controlled trials, you throw them all in a blender, and you pour out a single number. The profound danger there is false precision, because that number doesn't actually mean what it appears to mean. A case report is powered entirely differently than a trial. Tier-segregated mapping, which is what Stage 5 uses, is more like a neatly separated bento box. Case reports stay in their compartment. Observational data stays in its compartment. RCTs stay in theirs. This means you can see exactly which part of the literature is making the conclusion, allowing you to actually judge if that specific tier is suited to answer your clinical question. Section 1. The Snake Venom Paradox, a PubMed literature-worked demonstration. To test this framework out in the wild, a PubMed demonstration called ASV Full mapped out every single piece of anti-snake venom literature. The framework's creator, Dr. Avinash Kumar Gupta, actually built this open, worked demonstration by pulling primary literature straight from PubMed. They extracted every single case report, systematic review, and RCT they could find into a running trajectory map, perfectly segregated by tier. Which leads us right back to our medical mystery. When we look strictly at the highest tier of evidence in our neatly organized bento box, do randomized controlled trials actually establish a mortality benefit for snake antivenom? The answer, shockingly, is no. When we read across the tiers, instead of pooling them together, we see that the RCT and meta-analysis tiers completely fail to establish that snake antivenom saves lives. Now that is a truly terrifying thought, until you look at the rest of the evidence map. The mortality signal, the actual proof that this treatment works, lives almost entirely in the lower tiers, the case report and observational tiers. It's found in the recurring severe outcomes of patients who unfortunately didn't get the antivenom, and it's found in historical clinical judgment. The framework emphasizes that this isn't a failure of the data. It's actually a highly legitimate, citable finding about the true shape of the evidence, rather than some forced consensus manufactured by a blender. And this brilliantly illustrates exactly why evidence mapping is so incredibly crucial. Why don't the RCTs show a benefit? Well, because a randomized controlled trial that withheld antivenom from envenomed patients in order to test its mortality benefit would be fundamentally unethical to run. You cannot take a group of patients bitten by venomous snakes, give half of them the life-saving cure, give the other half a placebo, and just wait to see who survives. It would literally be a catastrophic ethical violation.
So, the crucial point we need to take away here is this. If you just blended everything together into a meta-analysis, the lack of RCT data might dilute the overall score, making it look like the antivenom isn't highly effective. But by segregating the data, we realize that the absence of high-tier evidence isn't some gap waiting to be filled by a future trial. It is a durable, structural feature of the clinical question itself. The observational data and case reports have an incredibly strong signal precisely because we can document what happens when people don't get the treatment in the real world. If we casually pulled all this, we'd erase that critical distinction and arrive at a completely false, downright dangerous conclusion.
Section 2, Radically Transparent Limitations. Naming the guardrails.
The Vibrowns framework is all about radical transparency, naming its own guardrails right up front rather than leaving them hidden in some fine print for a reader to stumble upon later. So let's look at exactly what those are for the ASV demonstration. First up, incomplete sampling. The corpus right now is a work in progress. They started at 12 out of 78 available case reports and are currently expanding, maintaining a really strict log for anything that gets excluded. Second, it uses a single LLM-assisted extractor. They don't yet have an independent second human reviewer, though they do spot check against the source PDFs. Third, there's no pre-registered protocol yet on platforms like Prospero. That means it's a rigorous synthesis, for sure, but not a registered one. And finally, the RCTs and case reports are currently analyzed in separate passes rather than being fully integrated into one single trajectory view.
So what does all this actually mean for us? It means that outputs at this stage 5 layer are wonderfully transparent, source-traceable drafts. They're meant to be a method for a learner to verify claims against the primary literature for themselves. The Vibrowns framework is highly explicit that this is absolutely not a substitute for a peer-reviewed statistical meta-analysis. It's a draft. It's an incredibly well-structured working demonstration, not a final, standalone, citable finding. It basically empowers you to see the map of the evidence with your own 2 eyes. Which leaves us with a truly profound question to ponder as we wrap up. As we saw with the snake venom paradox, simply demanding the gold standard of evidence can sometimes actually blind us to reality. So if we adopt the discipline of Vibrowns Stage 5, if we use evidence mapping to respect the natural shape of the data, and we stop forcing consensus in a blender, what other medical truths might we uncover? What other life-saving signals are hiding right now in those observational tiers, just waiting for us to map them correctly? Thank you so much for joining me for this explainer. I really hope it has fundamentally changed the way you look at medical evidence. Keep mapping, keep questioning, and keep learning.